Welcome back, everyone. Uh, Today we're going to be looking at the medicine block of this work, something we're really excited for. And I just really want to take the opportunity to thank Ivy and her entire team for really gifting us such an impactful initiative over the years. As Ivy said, I'm Christopher Simon. I'm the director of physician wellness and medical culture at the Canadian Medical Association, and I'm really thrilled to kind of be a part of this culminating dialogue for this Healthy Professions Workers Partnership. As they always say, we're here for a good time, not a long time, but I'm really looking forward to seeing what we have coming up next for where this work can go and what further impact it can have. Um, like some others listening in, I'm also hosting this session on the traditional unceded territory of the Algonquin and Anishinaabe people, colonial known as Ottawa. And as for my presenters, we have two today. However, I'm going to introduce both of them, but I just want to remind everyone too, it may or may not have been the agenda, but one of them is going to be a pre-recorded session by Dr. Elena Neiterman, the first, or actually we're going to do it second. She was unable to be here and she sends her deepest regrets, but we have some recordings and we'll still be able to go through the presentation and address some of the great content. Dr. Needham will be speaking to how can we improve the mental health and well-being of physicians in Canada. And Dr. Needham is a lecturer and researcher within the School of Public Health Sciences at the University of Waterloo. Her research examines how to build a sustainable health workforce by improving retention and removing barriers. Now, up first, we're going to have Dr. Sarah Simkin, who's going to share with us the work on physician mental health experiences over the life course and policy implications. Or did I switch those? I think you may have been switched to my thing, but that's okay. They both definitely flow together. Dr. Sarah Simkin is a family practice anesthetist and health workforce researcher. She is the health workforce planning theme co-lead of the Canadian Health Workforce Network, as well as the medicine case study co-lead. And she's also an assistant professor at the University of Ottawa. Like some of the other presentations we've heard this morning, we'll hold some of the questions to the very end, just to make sure we can get through both of the presentations. First of all, we're going to start off again with Sarah here in terms of how we can improve the mental health of physicians in Canada.
Great. Thank you so much, Chris, for that introduction. So today we are going to talk about what we can do for mental health in medicine in Canada. I'm going to summarize the learnings from the Healthy Professional Worker Medicine case study on behalf of the medicine team. In terms of background, we know that when physicians are unwell, it can compromise the care that they provide. We also know that physicians are known to suffer from rates of depression, anxiety, and suicide that are higher than in the general population. And increased awareness of mental health issues has been helping us to have a discussion, a conversation about what can be done about this. So the objectives of today's presentation are to dip into HPW data to examine common drivers of mental health issues among physicians and to look at promising practices that can improve the mental health and well-being of physicians. I'll be drawing on results from the literature review, from the survey of physicians and trainees, and from interviews with physicians and stakeholders. So the survey confirmed that mental health issues are prevalent in the physician population. 60% of physicians responding to the survey suffered from a mental health issue during their career training. We define mental health issues broadly as mental or psychological stress or distress, burnout, anxiety, depression, other mood disorder, substance use or dependence, post-traumatic stress disorder, or serious thoughts of suicide. Of those who suffered from a mental health issue, 51% considered taking a leave, but only 18% did. Of those physicians who did actually take a leave, 79% returned to work. 54% of physicians made changes to work as a result of mental health issues. And these results are generally concurrent with the other professions, except for leave taking, which was less common amongst physicians compared to other professions. A variety of themes arose from the interviews. We heard that work can provide a reprieve from family stressors, but that it can also bring challenges, including guilt around being an absentee parent. We heard that different practice settings result in challenges and that mental health issues vary depending on specialty and the type of work that physicians engage in. We heard that health and wellness interventions sometimes don't reach those who really need them. We heard that medicine selects for traits that make it less likely that physicians will seek help. We heard about barriers to seeking help, including concerns about confidentiality and licensure. And we heard that there are often no clear structures in place to support leaves of absence, and that there's a need for clear return to work policies, supports, and processes, especially for trainees. And finally, we heard that gender roles, microaggressions, and emotional labor are burdens that accumulate over time and that contribute to mental ill health amongst physicians. Here are a few things that physicians said in the course of the interviews. Medicine selects for people who have perfectionistic tendencies, selects for people who sacrifice their own needs to meet the needs of others, who can delay gratification. And so there are lots of things in there that might lead to mental ill health. We heard that the two messages in training are the patient always comes first and show no weakness. And that's not a particularly healthy message. We heard there's an expectation if the patient always comes first, that your need for a break for lunch, to leave at 6 o'clock, to do those things is irrelevant. And finally, we heard asking for help. It's an unspoken rule that you don't do that because you need to be tough. These quotes give us a window into medical culture and into what we might be tackling when we try and change that. We segmented the drivers of mental ill health amongst physicians into three categories, which should be familiar to you by now: structural factors, workplace context, and personal factors. The quotes in the previous slides highlight some of the personal factors, some of the selection criteria that results in physicians who are both innately less likely to seek help and then discouraged by the culture from help seeking. We heard about gender roles and microaggressions that add additional burdens and that slowly build up over time. In terms of workplace context, physicians feel that it's simply impossible to take time away to recharge, to prevent mental health issues from getting worse, or to address issues that are severe enough to interfere with their function. Physicians are reluctant to access support due to concerns regarding confidentiality, reputational concerns, and licensure concerns. And in some settings, access to mental health services can be challenging. Things that come to mind are rural and remote. And in the current landscape where mental health professionals and resources are thin on the ground. In terms of structural factors, medical culture can be a stressful and unsupportive, can mirror the stressful and unsupportive work context that physicians function within. And the lack of support, demanding work schedules, and inflexible conditions can worsen mental health issues. So, these drivers and the categories that we place them in can be helpful in terms of identifying interventions that we can apply to improve the situation for physicians. So, what do? We've identified a series of promising practices based on what we heard and learned in this study. We heard that planning for workforce efficiency and safe and adequate staffing is important. Some degree of redundancy in the workforce allows physicians to cover for one another, supports both long and short term leaves, and overall facilitates better work life balance. Some physicians have access to this, but most don't. A centralized locum database would make it easier for physicians to find help to cover their practices and their commitments while they take the time that they need. Insurance coverage and leave navigators can help physicians work through the process of taking a leave. Financial support for physicians on leave is important. Doctors told us that being able to get a bridging loan would have helped them take the time they needed to address mental health issues without making the financial stress of the whole situation worse. Clear, equitable, and accessible policies with respect to bullying, harassment, and the other things that make mental health worse in the workplace for physicians are necessary. Also, understanding entitlements, resources, and supports that are available, particularly for trainees, is important. We heard that accommodations and gradual return to work would be really helpful. This is uncommon in medicine and definitely not in a formalized way, and would help physicians to reintegrate into the workforce successfully after a leave. Trainee empowerment is something that would help medical culture change, help us to value mental health, talk about it, and interrupt some of the patterns and conditions that are perpetuating stress and distress. This is happening, but it needs support from those of us who are in leadership roles and those of us who are more established in our practices. We heard that peer support and leadership are strategies that can help physicians with their mental health. And finally, wellness breaks and mental health and well-being resources are things that should be integrated into all medical workplaces. I'll leave you with three key messages. First, patients need a healthy medical workforce. And just a reminder, we are all patients, so we all need this. Second, we need to invest in the well-being of physicians by building access to a range of formal supports at the individual, workplace, and system levels. And finally, there's an opportunity to change medical culture and promote mental health and well-being in medicine. And this study is helping to advance our understanding of what it takes to improve physician mental health and to make things better for everyone.
Fantastic. Thanks, Sarah. So, I mean, I have so many rambling thoughts I want to share, and questions and everything. I think it's fantastic, but I'm going to hold some thoughts to the end, and I think we're going to jump right into the next presentation.
Yes, absolutely. So I'll just present that on Elena's behalf. Elena is celebrating a Jewish holiday with her family, Shavuot, that just starts today. So hopefully you can hear this well. If not, please just turn up your volume a bit.
This paper, wait.
Oh. Sorry.
Mental health of physicians has been identified as an important issue in health human resources. The literature suggests that physicians are more likely than many other knowledge workers to experience mental health issues, stress, and burnout. In this presentation, we examine mental health of physicians using a life course perspective. A life course is an interdisciplinary approach popular in gerontology and developmental studies. The life course perspective aims to understand how individuals' development is impacted by the movement across their life course, from birth to adolescence to old age. The life course approach explores how our life and personal biographies are shaped by social location and social context, offering a perspective that bridges macro and micro analysis. That is, our individual biographies might be shaped by specific life events and transitions, such as marriage, childbearing, or a move to another province. These transitions define our life trajectories and may impact our later life experiences. In addition, a life course perspective also considers the role of social location, including gender, ethnicity, income, as well as our age cohort's impacts. And then at a macro level, the life course approach examines how major economic and political events such as recessions or COVID might impact individual life experiences. In this presentation, we apply life course perspective to the analysis of mental health issues among physicians by considering how early, mid, and late career experiences might shape physicians' mental health and well-being. Specifically, we explore what are the mental health challenges across the professional life course of physicians, and what mental health concerns are particularly prevalent during different stages of their professional careers. The data for this study was derived from a larger HPW study that examined leave of absence and return to work among knowledge workers. As you may have already learned, we used the mixed methods approach, which included a review of the literature, surveys, and interviews with physicians, stakeholders, and workers. This particular paper draws on the literature review and the interviews with 29 stakeholders and 21 practicing physicians. We applied thematic analysis to analyze the data and consider what role do career stages play in mental health and well-being of physicians. Examining what causes mental health issues among early career physicians, we found that personal and familial issues, such as caring responsibilities or concerns about their ability to do well in residency or in practice, might have caused physicians stress and strain. Gender and race or ethnicity might have further exacerbated these issues, with women being more prone to experiencing family-related stressors. On a positive side, we found that early career physicians in general were more open to discussing their mental health issues and were open more to seek supports. However, there are some institutional barriers that we identified that often made it more challenging. For instance, those who were in residency were concerned about the rotation, and taking a leave of absence during rotation meant that sometimes you needed to just redo the whole rotation on a different schedule, which might have posed additional challenges. In addition, the early career physicians were feeling that the control that they had over their schedules and over their practices was not great. And they had to establish themselves and position themselves as respectable professionals, which was another barrier for seeking out help and taking a leave of absence when feeling unwell. Mid-career physicians, the accumulation of stress and burnout resulted in feeling unwell. Some of the participants talked about developing good coping skills to deal with stress and burnout, but the accumulation of stressors was also growing, which made it more challenging to deal with these issues. Similarly, for this group of professionals, mental health issues were linked to stigmatization in the workplace, which was particularly evident among male physicians. We also noted that there are some institutional barriers for taking a leave of absence due to mental health issues. Those physicians who worked with colleagues often felt that taking a leave meant dumping the work on their colleagues, which they felt uncomfortable about. And for those who were working in private practice, financial considerations such as maintaining a practice while on leave or not being paid while on leave were also some of the major barriers discussed by the participants. Those physicians who we identify as approaching their late career demonstrated remarkable resilience. They talked about the change in culture that they witnessed over the course of the practice in relation to mental health issues. Some of these participants talked about the role they assumed to advocate and mentor younger professionals. And while they found these roles rewarding, they also added more work onto their plates. Late career physicians also identified physical demands of their work as growing, along with the complexity of the patients. The concerns about retirement income were particularly prominent, especially for those who maintain private practice. So at the organizational level, the lack of retirement income and lack of money to rely on it taking the leave of absence were one of the key concerns for continuing to experience mental health issues without taking a break from work. To summarize, while mental health of physicians continues to be a concern, there are differences in how these concerns are experienced, which can be illuminated by examining the mental health issue through the life course perspective. While mental health issues affect all physicians, the career stages oftentimes define pathways of impact of mental health issues on physicians. Specifically, the results from our study showed that early and mid-career physicians are particularly vulnerable to mental health issues due to various stressors, including to personal, organizational, and macro-level factors. To address these issues, we suggest that interventions to improve mental health and well-being of physicians should be specifically tailored to career stages to address the unique needs of physicians. Thank you for listening.
So I'll pass that back to you, Chris.
Okay. Thanks, Ivy, and thanks to Elena. I hope we can send her a message later just to thank for that great presentation. Also, I believe we could also commit to recording any questions that maybe any folks may have for her that we can share and kind of circle back if anyone has anything specific at the end. So. Okay, so like I said, I do have a couple rambling thoughts because again, I get quite excited with this topic. It's a passion and something that has a lot of impact across the health workforce and the health system. And I just kind of want to share a couple thoughts before I open it up to the floor, if you'll kind of indulge me for a moment. But first, just a PSA for both presentations. I really appreciate the focus on the mixed methods and qualitative element. I think just the richness that you get from the qualitative pieces and being able to compare that and contrast that and complement that with the quantitative data is something that is sorely lacking in this space, I know, quite often. And I think it's something that gives us such rich detail And also, when you try to bring data more to the public, having stories and ways that you can bring the story of the data and other research is trying to tell can really help kind of give that texture and make things connectable. And that kind of ties into one of the first themes that I noticed is really just this march around the humanization of the professions a little bit more, and leaning into that aspect and how important that is. Looking at the professional life course and looking at not just focused on the prevalence rates of burnout, which are burnout and other outcomes writ large, but looking at the drivers that could happen at all the different life stages and what being able to act on those drivers can mean. So, I mean, you could have similar rates of burnout or any other type of negative outcome across early, late, mid, and late. But the drivers could be different within there. And if we don't address those, it's really hard to build impactful initiatives that can have a lasting impact for different individuals based on those different needs. So that's some of the things that were kind of sticking out to me on that piece. Similar to some of the other things too is it's this whole piece that Sarah was talking about that really struck me around this whole medical culture piece, looking at those structural factors, the cultural things, the lack of what I would call, psychological safety, and some of the issues that we see there. There's this pervasive sense of self-sacrifice, this valorization of mental toughness, which again speaks to that, and which is kind of paired with that, self-selection that medicine tends to have sometimes in terms of personality traits and other things that kind of come into play. And one of the biggest challenges that we're seeing is when these factors and these traits that are held so close to one's identity and you as a person really come into conflict with just the basic limitations that people and humans have in terms of workloads, in terms of other challenges, in terms of other interests that we have, other things we want to integrate into our lives. And we're starting to see this confluence of factors really kind of butt those two things together. And it's creating a lot of issues in terms of workload, cognitive load, and just the impact and the dissonance that people feel. And it does lead to a lot of distress and is one of those big issues. And really, again, we can nibble around the edges and look at all these different drivers and ways that we can impact wellness and improve things. But if we don't meaningfully address just the sheer amount of time that people spend at work and the amount of driving factors we have around workload and the issues like that, that it's really hard to focus on how we can better integrate work and life together, how we can help nurture multiple identities and other ways that we associate ourselves. And, we're seeing signals for change for this. There's an article on CBC the other day talking about ways that physician recruiters and retention folks are trying to focus on different things and being really creative in terms of how they attract and retain physicians, especially in rural communities. And the fact that they're being creative is not interesting and not new, but what they're focusing on, I find very fascinating. I think they even had a focus on things like putting up Christmas lights and helping people order good foods, organize play dates. What's the school situation like? Helping, and really, again, it ties back to the whole idea of the humanization of the profession and how emerging generations of physicians, especially when faced with some of these extreme workloads and other sort of factors that we're facing, and the lack of ability to take time off and nurture these other things, people are less and less willing to compromise on these. And that's becoming more and more prevalent in terms of a desire, and the needs aren't being met within the system. And I think that's one of those large factors that we have. So all this to say, I really love all this work. I love the focus on the early, mid, late career, looking at all these different factors that can come into play. And really, I mean, I would challenge everyone to look, beyond some of the negative factors by looking at burnout, looking at some of these other negative outcomes, and start to look at how can we measure and look at more positive indicators and look at the drivers of those. So looking at things like professional fulfillment and the impact those things have in the workplace, because I do think that those dovetail with what we're seeing from some of this qualitative work. And finally, I mean, one of the scary stats that Sarah was bringing up, the whole 54% intend to make changes, whether, whatever those look like, we don't exactly know, but that very much aligns with some of what CMA's MPHS National Physician Health Survey data was saying, that, in the next 2 years, over half the profession intends to reduce their clinical work hours. People are looking at ways to reduce the impact that their work life is having on their personal lives and their lives. And they're looking at ways that they can improve their level of professional fulfillment and satisfaction. And if we don't help them get there, if we don't take meaningful action, then it's going to come back and again continue to exacerbate these broader health workforce challenges that we have. So with that, I'm going to open things up to the floor. I don't know if I can see everyone's hand. Oh, there we go. Of course, Carolyn, my plants in the audience, has a very good question, I'm sure, coming up.
Well, maybe a bit of a comment, and I just wanted to say first, thank you for 2 great presentations. And what struck me is how consistent the results were with not only my experience or what I've seen through the years, but also, as Chris said, some of the data that we also have through the National Physician Health Survey. I just wanted to touch on a couple of points regarding return to work. I think, unfortunately, our system for physicians just is not set up to help us with those things. And I remember in 2010, I was working at the Ottawa Hospital, and I was part of this female physician leadership committee, and we pulled together just to try to address some of the gender differences that we experienced. And one of the first things we did is we wrote a policy on leave of absences, and highlighted it's not just for a sabbatical, but it's for adoption leave, it's for elderly parent care, it's for your own wellness. And just to say that you'd need to work on those policies and processes so that it makes it easier for docs to actually take the time when they need it. The other point that I really appreciated as well is the guilt, Sarah, that you highlighted. Guilt, shame, that altruistic kind of sense that, yeah, people are picked for that and for that perfectionism. And unfortunately, so the docs over years have just stretch as the system has been asking them to, and no one is there to safeguard, like to say, no, you are one person, you have 24 hours. There's a point where you say no, and unfortunately, even medical legally, the buck stops with us. So it makes it extremely hard to say no to that one last patient. The demographics and that life history is really good. And some of the chat comments, if you go before those, like the early career for the med student part, and you guys may have heard this, students come in healthy, resilient, and it's by year 2 of medical training that boom, that burnout starts to hit, and that stress really has an impact on their wellness. So fascinating to see it. So I just wanted to say again, thank you for data. We need to use data for advocacy and for system change. So thank you for adding to that. And it'll just allow us all to work together and make the culture and the environments and the system better. So thanks again.
Thanks, Carolyn. Yeah. I think. I mean, the one thing I would add there is, as Sarah said, there's those different areas of impact. There's the personal factors, workplace, and the more system level ones. And I would argue that no broad scale change is going to happen unless we have attention given to all 3 of those factors. You can't look at any one of those in a vacuum as some sort of silver bullet. That you're going to need action across all of these, bottom down to top up, and meet in the middle. So, Ivy, you had a question in the chat, I believe, for Sarah. Did you want to articulate that, or?
Sure. Yeah, I just wanted to get a sense. There was this like point in your summary about plan for workforce sufficiency, and often we think of planning as quite distinct from worker wellness. And so I'm wondering if you could draw that path for us based on the data. Thank you.
Yeah, sure. Thanks, Ivy, for that question. We heard over and over again, I can't take an hour away to go to the dentist. I can't take half a day to take my elderly parent to an appointment. I can't take a week off for a holiday. I can't take the leave that I need. And that's because there is nobody to fill in. So our workforce, our physician workforce, is so stretched that physicians, every single minute is filled. And if you don't deliver this service, there's nobody else to do it. We need to change that through planning. We need to say, and we've heard today, just now, that people are planning to reduce the amount of clinical service they provide. We need to anticipate that this is going to happen and say, okay, if there is less capacity for clinical service, then we need to make up that capacity somewhere else. We need to build redundancy into our system so that the coverage for those dentist appointments, for the care that's given for holidays and for leaves is available and easy to find. So the Ontario Medical Association is busy um, producing or advocating for and designing a provincial locum program so that every physician will have access to locum coverage to allow them to take the time they need for whatever that is. And that is part of planning. And so if we take a proactive approach to figuring out what physicians need in order to flourish in a sustainable health system, and we plan for that, I think the one of the end results is going to be better mental health and better outcomes for our patients. That's how I draw the line between these things.
Thank you, Sarah. So it's like a North Star for what it is, why we're doing planning is just ultimately, and I think Chris, you spoke to that, the quintuple aim.
Yeah, and even beyond that, so again, I forgot to mention that another thing I appreciated just was those list of actionable things you can do, even just starting today sort of thing. Sarah, just at the end there, those actionable items. I thought that was fantastic, but it also kind of raised one of the challenges that we see is that we spend a lot of time sometimes in terms of building these really well articulated, well designed, very thoughtful actions and resources and supports and things like that. But then we do it's called the field of dreams paradox, right? It's like you go on the assumption that if you build it, they will come, right? And I think that's the challenge, is the assumption that if you just build this really well crafted resource, that everyone will use it. And we saw that in some of the data you talked about in terms of fears of confidentiality, fears of anything. But one of the things that was surprised me with our last national physician health surveys, we looked at challenges and barriers to access to care and things like that, and barriers to reaching out for support. And a very close number two was confidentiality, and number three was fear of retribution and things like that. Guess what number one was? Not feeling that you felt you were deserving of or felt or met the threshold for care or support. So people have this, again, it's this cultural piece that we talked about, is that you feel that it's not for you. You have to be so much worse off. And there's so many other people who are worse, who are way worse than you. So you're not deserving of these sort of things, these proactive promotion prevention pieces. So again, it just speaks back to that cultural element that you talked about as well earlier, that you also need to get to in terms of whether it's the modeling, I'm going to say leadership, at all levels in terms of building these things in. And that's critical in terms of uptake and implementation of these things too. So that kind of needs to go in lockstep with these amazing initiatives. So that's my soapbox for the cultural piece. But any other questions that we have?
Maybe I'll just, before we get to Kevin's question, I'll just add that mental health issues are one of those things that, by virtue of being mental health challenges, or by virtue of being unwell in a mental health type way, people may not recognize that they need help. So it's a little bit different than some of the other more visible, more clear reasons for needing to seek help. And we know that physicians, when they become mentally unwell, don't always recognize it, and it's just a different thing than if you've broken your leg and it's clear that you need to hobble around on crutches for a few weeks. So there's that, I think, that is just slightly different from other other afflictions that physicians might encounter.
Yeah, and again, ties back to that concept of psychological safety and fear of speaking up, not just speaking up, but seeking help and the impact that can have. Carolyn, is that an old hand, or do you have another comment or
Just a
question?
comment about return to work, which is one of the focus of the work that the group is doing. And it's a good news story. You know, heads of departments are not trained or informed on how to help physicians return to work. I don't know if that's part of what you're looking at. But recently, Chris and I were sitting at a meeting with Canada's physician health programs, and Ontario actually has done a lot of work in creating a pathway or kind of a template to really help hospitals bring physicians back, because so far it's been, well, you're either well and you come back and you're 100% full call, full clinical load, or we can't take you back. And that has to change. So the good news is that I think physician health programs are now going to learn from Ontario and spread that knowledge to empower the leaders to really allow, and it makes sense, right? You should come back gradually and increase. It makes sense. So that's one of the pieces I just wanted to say. I love the comments about just being human, which is so true. And if you look at the history of the physician culture, it was from being God-like to superhero to superhuman. And now we're saying, no, we're just humans like everyone else. So just thank you for some of those chat comments. So thanks again.
Yeah, if I could just interject, I think that's very similar to what Kim raised earlier for the nursing team, right? It's a double-edged sword to be acknowledged as heroic. And so there was a really great quote in the Healthcare Management Forum paper that we had from a physician specifically about return to work issues, is that, you know, there's no kind of gradual return in medicine. We also found that is a similar case in academia, which we'll be talking about after lunch, is that you come back and you have your full teaching load. There's no kind of coming back part way. And so it makes it very difficult, you know, to return. So I think that we need to be much more mindful of that. I also just wanted to point out we have a number of medicine team members, and medicine and the midwifery team were unique in that we included trainees in the survey and in the findings, so that enabled us to really expand that life course perspective. And I know comments were made earlier, or questions made earlier about, you know, how age matters. So I think that both Elena and Sarah's presentation really spoke to that. So in the chat, if you want to scroll up, because there's a lot of chat, Noor, who was a student of ours, did a poster looking quite specifically at BIPOC medical students. And so that really augments, so really want to kind of raise that. We don't yet have that on our HPW website, but we definitely should. So I just wanted to point out a couple of those things. So I'll pass back to you, Chris. I'm not sure if there are any other questions or comments.
Yeah, so do we have anything? Is there anything in the chat that I've glossed over or missed, or any not just questions, but any comments that anyone's offered that they want to amplify? Okay.
Maybe I'll
Well,
just,
if you need to capture a few minutes back in the schedule, we can hand things back to you, Ivy, and I think we have the dentistry team up next. So
Absolutely. I heard somebody. Was that you, Sarah?
yeah, no, it's all good. Let's go ahead.
You're good to go? Okay. Yeah, so thank you. Thank you so much. Really appreciate all of the comments, and we will have this recorded. And yes, if anybody has any specific questions for the work that Elena has presented, please pass that along.